Committee on Thursday, the 20th of November 2025, and we are now broadcasting, Jonathan? Thank you. So, earlier this year, the committee examined the Department of Health and Social Care Annual Report and Accounts 23-4. We raised concerns around the lack of plans to deal with cost of clinical negligence claims. The clinical negligence liability stands at an astounding £60 billion, having quadrupled in real terms since 2006-7. And this is the largest liability on the government balance sheet. Second largest liability, sorry, when I read that, yes, second largest, I think, after nuclear. Despite claim numbers plateauing over the last decade, the cost of claims has continued to increase, particularly for very high value cases over £1 million. We're also seeing claimant legal costs continuing to rise, with legal costs for claims under £25,000 being almost 4 times the total damages awarded. It must not be forgotten that behind these eye-watering amounts lie many tragic incidents of patient harm, and by far the most important issue is reducing the incidence of clinical negligence and harm caused to patients. Today's session will be an opportunity to examine why the costs of clinical negligence are continuing to rise, how the Department of Health and Social Care, known as DHSC from now on, is tackling areas where the costs of clinical negligence appear to be disproportionate, and explore options to improve patient safety while putting costs of clinical negligence on a more sustainable path. So we have a good cast of witnesses here today. We have Samantha Jones, the Permanent Secretary, with us. So, Samantha, would you just like to start by introducing yourself and then your fellow witnesses to do the same, please?
Thank you. Good morning. My name's Sam Jones. I'm the Permanent Secretary here at the Department of Health and Social Care.
Good morning. My name is Helen Vernon. I'm Chief Executive of NHS Resolution.
Good morning. I'm Aidan Fowler. I'm National Director of Patient Safety and a Deputy Medical Director at NHSC and a Deputy Chief Medical Officer at the Department of Health and Social Care.
Good morning. Elizabeth O'Mahony. I'm Interim DG Finance for the Department of Health and Social Care and also CFO for NHS England.
So, Elizabeth, have you appeared before the committee before? No. Of all the rest of you have, I think. No, I see shaking heads. Well, to all of those that haven't appeared before the committee before, a very special welcome, then I shan't get it wrong. I think you've all been warned, and I hope, Permanent Secretary, you've been warned. We are going to start with a few questions to start with on the whole issue of how we're reforming basically local trusts and redundancies and so on and so forth. So could I go straight into that, perhaps with you, and ask how the funding mechanism for these redundancies will work?
Thank you. So I will start and then, with your permission, ask Elizabeth as the DG to pick up the details, if you're comfortable with that. So as you were aware, the Prime Minister announced in March the abolition of NHS England and bringing the functions of NHS England back into the Department of Health and Social Care. And we've been working through what that means in practice since then. In fact, when I came before the committee previously, you asked questions around that as well. We started last week with the joint executive team, which is bringing together unified leadership across the Department of Health and Social Care and NHS England, while still remaining 2 separate bodies for obvious reasons until the bill has passed through Parliament. So what we're trying to do is model what we're asking everybody else to do, which is bring together the leadership to reduce the duplication, reduce the variation that's happening between teams, and making sure that we reduce the bureaucracy associated with it. And the joint executive team, otherwise known as the JET, met for the first time last week, and as Elizabeth said, she is the Interim Director General for Finance, including and also in her role as CFO for NHS England. As part of the announcement, the Prime Minister committed to the reduction in terms of numbers of staff by 50% across the national body, which is the Department of Health and Social Care, and we have been working through some of the detail around what that looks like and how that will be funded over the next couple of years. And indeed, last week, on I think the 11th of November, the Secretary of State set that out in terms of a bit more detail, as did Sir Jim Mackey, Chief Executive of NHS England. And with your permission, I'll hand over to Elizabeth to talk through the detail.
Elizabeth, please. Yes.
Thank you.
Thank you. Really appreciate that. So I would start by saying, obviously, reform of this size is always going to be challenging, and we've approached this through the spirit of ensuring that any savings that we make will undoubtedly go to be reinvested in frontline services and benefit patients. That's first and foremost, and I think we have to keep that in front of our mind. The way that the funding flows effectively is we will be we have released very recently a voluntary redundancy scheme. We've engaged with both ICBs, NHS England staff and the Department of Health staff to ask if there are any volunteers to come forward for that scheme, which has now been approved more formally. And essentially what happens is we are looking to identify in the region of about 50%, which is about 18,000 posts that will be made redundant. Some of those posts are actually vacancies. We've had quite a lot of natural attrition over this period, and those redundancies and those funded posts will effectively pay for the redundancy costs going forward. So it will be cost neutral over this Parliament, and effectively, again, over the next 3 years, we would anticipate that the changes made will save in the region of £1 billion over the next 3 years, and then £1 billion recurrently going forward, because obviously the main thing and the key thing to this is as we reduce our headcount, we must not increase our headcount going forward. So that's going to be absolutely key for us. And just to say that £1 billion, I suppose, I always put it in the context of I very recently worked very close to the front line. That £1 billion is effectively, over 100,000 hip and knee operations, and would be very welcome in terms of our recovery statistics.
That's really helpful. So we know the headline of what you're trying to do. This is a very large redundancy programme, 18,000. How much is that going to cost, and how is it going to be accommodated within the DHSC budgets?
So the true cost, we genuinely are working through that, mainly because of the 18,000 currently, that is split around about 50% for NHS England, the Department of Health. We're already carrying in excess of 3,000 vacancies, so those staff don't exist to make them redundant, for example. And also, when you're making staff redundant, as in people are taking up a voluntary redundancy scheme, it does depend on the grade of the staff, it depends on their length of service and other things. Because the voluntary redundancy scheme has recently been announced in the last couple of weeks, and we've launched a scheme, we're asking for volunteers, that will need to be calculated, so I can't give you a firm numbers there. We've got obviously initial estimates, but that's as good as we've got. But then to say effectively the funding is by actually those staff no longer being paid going forward, it releases a funded establishment which would pay the cost of redundancy, so it's self-financing over the term.
Over the term, but how are we going to deal with it in the interim? So you've announced the programme. As I understand, that triggers whatever cost in this year's accounts, which haven't yet been budgeted for. How is that going to work?
So effectively, we are looking at once we've had the voluntary redundancies come forward, and we know the scale of redundancies, voluntary redundancies for this year. Also within ICB allocations and at a local level, there is some flexibility within those allocations. So at a local level, there's not a standard amount. So some ICBs have got more flexibility than others. So we're working at a National Health Service level to try to afford and accommodate as many voluntary redundancies as we can this year. That does depend on the voluntary redundancy costs. So we're effectively bringing forward or trying to profile our money to suit to accommodate the cost of redundancies, recognising that these redundancies need to be made within a 2-year period. If I just give you one example, if I may. So depending on the flexibility this year, we will make some redundancies this year. in the event that we can't do as many redundancies because of affordability, these redundancy costs are self-financing within an annual cycle, so we would phase them to effectively.
I'm still not, I want to be absolutely clear.
Yeah.
It's maybe just me, and I'm sorry if it's just me. I want to be very clear about this. You're asking ICBs and other local systems to make a substantial number of people redundant now. Yeah. You're going to have to pay the cost of that in this financial year, for which many ICBs and local systems have not budgeted for. They don't have the money. Where are they going to get that money from?
So over the 3-year over the settlement.
It's an issue of cash flow. Parliament has voted a certain amount of money in its vote, and they won't have any extra money to pay these redundancies. So what is the mechanism? And I understand it's going to be self-financing over a period, but in this financial year, where is that money coming from?
So in this financial year, which we cannot confirm an absolute number at the moment because we're working through the detail, when we know the detail of that number, we are effectively looking at, can we manage some of our budget from future years into this year to afford the redundancies at a rate that is affordable for home spending.
Now we're getting there. So some money is going to be brought forward from future years. Now this committee is used to dealing with money. We have a vote in Parliament. We've voted a certain amount of money. If it's going to be brought forward from future years, what's the mechanism for doing that?
It would be in an agreement with Treasury.
And there'll be a supplementary vote. Right. Now we've cleared that up. Thank you very much indeed. Thank you. Sorry to labour that a bit, but I thought it's important we get that on the record. Clive Betts, please.
Yeah, I mean, we've had this discussion before at the committee. It's a very possibly short timetable, isn't it? I mean, you announced this in March, but it's only this month that you've given the go-ahead to actually do redundancies because they can be paid for. So have ICB's basically got 4 months to sack people?
So I think we would absolutely acknowledge the challenge of the timetable. We would also absolutely acknowledge and both all of us as individuals and as the Secretary of State said, recognise the uncomfortableness there has been over the last few months while we've been working through the detail of how the schemes will be delivered. I think Elizabeth will walk the committee through exactly what the ICBs have been asked to do over the next couple of months. What we've asked for is people to come forward for voluntary redundancies and to take place over the next few months. But in terms of the detail of with the ICBs?
Yeah, so when the announcement was first made, in a matter of about 6 weeks, working very closely with ICB chief executives at the time and their boards, a model ICB scheme was developed, thinking about the future roles and purpose of ICBs as strategic commissioners and no longer requiring to have oversight of the provider sector. That work has continued. So that work has happened and continued. They've had expressions of interest. They've engaged with unions. They've engaged with staff with the expectation that at some point a voluntary redundancy scheme at a national level would be approved. So whilst I agree it's a short time frame to make the changes, the planning has started at the time of the announcement.
Right, so all redundancies have got to be agreed by March, have they?
So the redundancy profile in aggregate is over a two-year period, so it's redundancies by March 28. 28.
Which is very different to what the ICBs locally are working out in my area, where they're telling everyone they've got to have it all done by March next year.
So because it's across the whole of the landscape, so it's both ICB's Department of Health and NHS England, and the ICB redundancies are a bigger proportionate part, then effectively ICBs are moving towards a running cost of £19 a head for the 1st of April. We're recognising the challenge on that and we're working very closely with them.
So what does that mean?
It means that people have put in place plans at the start of the year to move to a model ICB scheme and effectively they're trying to manage to that for the end of this year.
But if they don't, they can have extra money next year?
There's not extra money that's available next year, no. If they
don't get to the scheme that you're asking them to get to, and the reductions in staff by March, somebody's got to pay for the overrun next year, haven't they?
I wouldn't want to get into the details of the specific...
Well, I do, I'm sorry.
Sorry,
I think that's what we want to do as a committee, yes.
Sorry, of the specific ICB I was going to say. But all of the ICBs that I'm engaged with, they are confirming to me there's plans which can be delivered by the end of this year.
So every ICB will have to have in place all the necessary redundancies to get their budget down as you're requiring them to by March this year.
Yeah.
Next year. Yeah.
Yes.
Right.
And plans are in place, and we are engaging very closely with them, with
Right,
ICBs.
okay.
On
Now,
this.
you talk about this model plan. I mean, we were very critical in our report, which we appended to the issues we raised about reducing patient waiting lists the other day, about the lack of planning going on with these arrangements. Could you set out for us, maybe you can't do it now as a committee, what precisely ICBs do now, what you're going to ask them not to do in future, what you're going to ask them to continue to do, given we are talking about patient services, which of those provisions now will have to be met by somewhere else in the NHS, and which are going to have to be picked up by other bodies like local councils?
Now, if I may, I could also refer to, there was a letter that Sir Jim Mackey sent you, Chair, that I think outlined some of this in quite a bit of detail. I'm happy to talk through that if it's helpful. Or
Bring
we
that
can
up to
share
date.
the-
I mean, I'll just say, we were told, when Jim Mackey came before, and indeed when Professor Chris Whitty came, one of the important points is, will these reorganisations preserve the local place functions of the NHS? We were assured they were. Jim Mackey said, get in touch with them if they don't. Very frankly, and I refer to my own experience in South Yorkshire, but I'm sure it's elsewhere, what's happening is they are preserving the admin jobs at the centre and cutting the local place jobs. That's what I'm told, because they've never consulted the MPs, despite promise. It's all gone on in isolation, this. So we represent the communities, and they're not bothered with us at all. So Piers Butler, the chair, is carrying on to do what he wants, without any thought about the community MPs or the local place elements. Why?
Can I suggest...
I'm sure that's happening elsewhere as well.
I'm very happy for us to go away and look at the detail of the particular ICB that you're describing. But as Elizabeth said in Jim's letter, back to the committee after the last time we met, he set out what some of the functions would be for the ICBs and in terms of strategic commissioning. But we're very happy to take and go into a bit more detail outside of the committee and come back to you on
Right,
on
I've
that
got to
ICB.
say, given the importance of this to local communities, should ICBs be engaging with their local MPs on this and involving them in the process?
Yes.
Yes.
Yeah, absolutely. So there's in the letter that's followed on the 6th of November, clearly set out is a number of areas that we would expect ICB functional changes to grow, to retain and adapt, and to cease. And in the grow functions, it's around population health management, strategies around including pathway redesign, commissioning neighbourhood health, looking at risk management for neighbourhood team, commissioning pathways end-to-end for your local populations. So if anything, we are looking for these ICBs to move to be
Local
much more
MPs
local.
should be involved in this process. They should be consulted about what's happening.
We would expect any local ICB to be discussing and engaging with certainly local MPs.
ICB hasn't.
Yeah.
We get
Sure. Elizabeth, I, again, it might be me, but I want to try and clarify this a bit. If I was a senior executive in an ICB at the moment and listening to what you've said, I wouldn't be quite sure what my position was. What you've said, I think, is that there has to be a plan for these redundancies in place in every ICB by the end of the financial year.
Correct.
And that's the numbers. But then they have to open up an offer to try and achieve those numbers. And has that got to be done by the end of the financial year, or is it just that they're going to have a plan? So each ICB, each member of staff will know how many, but they won't have had an offer made to them.
So ICBs, all ICB staff will have had an offer made to them already.
Already,
Yeah. So the voluntary redundancy scheme has been launched for ICBs and NHS England and the Department of Health.
Right.
So that's already happened. The planning has started. So people were anticipating this would have happened. So staff were asked much earlier in the year, in the summer, for expressions of interest in the event that a redundancy scheme was launched. would you wish to be part of a voluntary redundancy scheme? We couldn't confirm the terms at that point because it was a national scheme. That has now happened. And effectively, those staff are considering if they would like to be made redundant or not, of a voluntary redundancy scheme or not.
They do know the terms.
They know the terms, they've got expressions of interest. We've got in excess of 3,100 staff at NHS England that have previously expressed an interest that they would like to go in this financial year. We are prioritising, because of the disruption at an ICB level, we are prioritising any funding available to manage that process first, recognising their process started so much earlier and the model ICB work is much further developed.
That's very helpful. I'm now going to hand over to Catherine to probe that a little more now that we've got that clarity, and thank you for that clarity.
Yeah, thank you. And just to reiterate, I think it is across ICBs that the challenges that Clive outlined are relevant. So I think it is really good to hear that this is the potential opportunity to really improve local healthcare provision and that connectivity with local communities. I just want to ask, is it your ideal scenario that we have 100% voluntary redundancies?
Ideally,
yeah, that is what you're working towards.
We're working to do. And if I could just expand, the other thing that we're looking for is we are looking to see if we can redeploy staff as well. So as functions are moving, some of the skills within ICBs are moving to other parts of the ecosystem, and in many places that I'm aware of, those staff are actually being redeployed, so there's not a need to make them redundant.
Have you given thought to where perhaps the geography might be more challenging? I'm from the northeast, it's quite a vast expanse, the ICB, and where it might not be so easy. So you may have a glut of voluntary redundancy applications from some ICB areas and not from others. So what are you doing to make sure that it's a coherent process?
In the current environment, obviously, many of these roles at an ICB level, for example, when I was working in the southwest, some of my staff actually worked in the northeast. So just recognising the ability to work and live in different geographies. The other thing I guess I would say is that the baseline position of all ICBs and the start position of all ICBs is not the same. So whilst people are making a 50% reduction in headcount, some ICBs were running at £65 a head, and some ICBs were already at £19 a head. So we are trying to work across systems, and particularly at a regional level, regional teams are trying to manage some of the issues that you're describing.
Yeah. I guess just going back to some of the issues that the Chair was raising around the financing of this, if you can't get 100% voluntary redundancies, how are you going to factor in the additional costs and potentially time as well that's going to be involved in moving to a compulsory route if that's needed?
Yeah, I would need to quickly test with my HR colleagues, if I'm honest, because the current conversations that are going on are the timing of the voluntary redundancy scheme. It would enable us to actually, in the event that we don't get to the point that we need to in terms of the headcount reduction, there would still be enough time in this financial year to launch and deliver a compulsory redundancy scheme.
Anna Dixon, have you finished, Catherine? Yeah, Anna Dixon, please.
Yes, I was pleased to hear from you, Elizabeth. Oh, sorry, I should probably just say, Chair, in terms of declarations of interest, I obviously previously worked for the Department of Health, and actually we do have quite a lot of constituents who work in NHS England in their Leeds offices who are going to be affected by this redundancy, and I think it's always difficult when you're talking about such large numbers. Obviously, it does affect people and their livelihoods. Coming to this point really around, with the voluntary redundancy scheme, we all know there is a risk that you lose the people actually that you need to keep, and you keep the people that maybe you don't need for the roles and functions that you've decided you need. So just really, and maybe this is coming back to you, Samantha, from a strategic point of view, how are you going to ensure that the people you keep have got the skills and capabilities you need for the roles and functions you've decided to keep? And that goes both for the centre and for the ICBs.
Thank you, and you are absolutely right. It is something that is a fundamental part of how we are moving to deliver the transformation programme in entirety. So I think I would just like to say that it is incredibly challenging, and we don't underestimate the impact on individuals involved, and we're very, very live to that in terms of support that we're trying to give people. None of us, though, don't think it's the right thing to do. And certainly that's what ICBs have certainly told NHS England, and certainly what our staff have said as well. When you're in such a challenging time, it is really important that we go back to that it is making the way we work, and therefore the way that we nationally support locally, easier. And obviously you'll be very well aware of some of the previous elements around duplication, man marking, that really didn't add value to what should have been happening locally. And that remains the thing that keeps us focused for the future. In terms of your specific questions, through the transformation programme, we are looking at how we can identify and what schemes should be in place to identify those individuals according to the skill sets that we need in the future. And what we can do around both targeting them and also retaining them. I wouldn't want to go into particular detail now, but just to reassure you that as part of the programme, we are very, very cognizant of that and looking at how we can do that, including using schemes from across broader Whitehall and the broader civil service around recognising how we maintain the right type of staff that we can. So I'm happy to come back with a bit more detail on those schemes, but we are very live to it. Through the bringing together of the joint executive team, each individual now has responsibility from a national perspective for colleagues across both NHS England and the Department of Health and Social Care. So we're very clearly now looking at teams in entirety rather than perhaps what there had been, well, in fact, what there had been previously, while still maintaining absolute terms and conditions of the different organisations. And so, for example, I'm sure Elizabeth can talk for herself rather than me, but looking at the skill set across the finance function and the commercial function that she has responsibility for, and identifying those individuals that we need to keep. We're very live to it, and now that we have the schemes have been launched in the way that Elizabeth said, we can now understand the kind of profile of the plan that we're trying to work to over the next couple of years. I would say that we are also underpinning this programme with trying to do a proper organisational change and organisational development support from a cultural perspective, recognising that bringing different organisations together and they're very different, certainly with teams within NHS England and then teams within the department. So actually doing a lot of work around the culture between the different organisations and what we're trying to create for the future. And importantly, in line with the reason that the Prime Minister announced this originally, to take as much as possible locally down to local places, hence the question that was asked earlier, and that remains our focus.
I mean, you're absolutely right. I think I arrived in the department in 2013 when the Landsley reform to separate the Department of Health and the NHS was taking place. And obviously with various mergers of organisations and arms length bodies into NHS England, it's ballooned over time. So, absolutely see the need to reduce duplication. I suppose one of the things that I would be concerned about is, there has always been a recognition that there's different skill sets and different cultures between those who are in civil service and those who are more operationally focused within the NHS. So I do think you mentioned it, but I think not underestimating both the challenge of creating one team, one culture, but actually the NHS not sort of eating the department, which I think we've seen in terms of culture in the past. Devolution, yes, but how are you deploying people into place and providers? So is that one of the areas where you've talked about redeployment? I'm just trying to get a grip on how we don't lose some of the people and the skill sets, not just from the NHS England and ICBs, but also redeploying them into providers, into the wider public sector. So perhaps, Elizabeth, could you answer a little more about the redeployment scheme, or is that something you wish to follow up in writing?
Well, if we may, we'll follow that up in writing. But can I just take the first point that you made? As you will be aware, I've had the privilege of both working within the service as with an operational focus and also in Whitehall in the civil service. And yes, it is different. It is different. However, it is also not true, not that you're saying this, that one hospital is the same as another, one department is the same as another, and actually, or similar from a Whitehall department. And what we're actually trying to do is bring together a department that can do both policy and delivery, and bring those operational strengths together. So when Elizabeth and I have a conversation, or when colleagues across NHS and the Department of Health are talking about various policy areas, it is so much better and so much richer when you have both policy and delivery together, because fundamentally the person at the other end is receiving, policy is only as good as its delivery and its impact, but we will come back to you on the specifics.
Thank you, Anna. You've covered some of the area that I was going to ask about. In redeploying these skills, one area does worry me particularly, that we're going to lose digital skills. Now, the NHS has very tough efficiency targets to meet. One of the only ways it's going to be able to do it is by improving its digital systems. How are you going to avoid that?
We're going to avoid not improving. Oh, yes,
losing really good in-demand digital skills which you may not get back.
So it in part goes back to the answer to your previous colleague. I think at the last committee I may have been slightly over-enthusiastic to the committee about the possibilities that data, digital and tech gives us. We know that the workforce of the future looks very different to the workforce as it does now. And indeed, the creation of the new department and thinking through what its role, functions and skills require, which we will do over the next period of time to create, subject to the will of Parliament, to create the new department, will include exactly the type of skills that we need. Specifically, on data, digital and tech, we have a significant programme which has actually been joint between the Department of Health and Social Care and NHS England anyway, and what we're actually in the process of doing is prioritising its work programme, including what do we need to do to make sure some really basic but quite fundamental housekeeping between the Department of Health and Social Care and NHS England works, meetings, sharing folders, etc. We shouldn't underestimate the importance of that, but also where things like AI, when we come to answer PQs, for example, correspondence, which is a particular focus of mine at the moment, and also supporting staff locally in outpatients and digital online, which I'm sure Aidan can pick up. So we are at a macro level looking at the skill sets that we require in the future, working across Whitehall with the Department of Science and Innovation and Technology about what is it that we can do collectively across government, how do we make best use of opportunities such as the app, and I'm sure we can come back to talk about that in a bit more detail. So looking and then supporting our staff through specific schemes to ensure that we keep the best and the type of skills that we need in the future, of which clearly this is one fundamental area.
Thank you, Permanent Secretary. I'm very anxious to get on to the main session on clinical negligence. There is one further question that I do want to ask, though, and I don't know whether you or Elizabeth asks this question. I think you have changed your procedures now in that people can't just walk out of one job into another job and still retain all their redundancy money. Could you just address that question?
Yes,
please?
Absolutely. Yeah, happy to, if you want me to pick this up. So under the voluntary redundancy scheme, which has recently been announced, in the event that it's a voluntary scheme, then effectively people cannot return to to work in the public service, actually across government, for a period of 12 months. So that's the scheme. Under the compulsory redundancy scheme, obviously that is an employment law. That is not a national scheme. That would be you wouldn't return within 6 months.
Okay, sorry, I wasn't being rude. I sort of have to run. Who wants what answer what questions next? But thank you for that answer. That's very helpful. I think I did say mine was the last, but actually Tristan has got one more brief question.
Just very briefly, as part of phase 2, you're announcing the potential restructures and new boundaries from April 2027. Can I just get some clarity, therefore, because you're going through redundancy rounds now, but in some cases you won't know the new boundaries for some of these organisations until 2 years in the future, because there might be even further mergers occurring. Is that really sensible that you're going through redundancy round now, then you possibly in 2027 you're going to have new boundaries and new mergers, and then have to go through another redundancy round then? Doesn't that sound rather ridiculous?
The overall direction to create the new department, of course, takes time in the way that we've been talking about today. I think without sounding flippant, change is a constant in the health and care service, particularly around how we ensure that we are able to move forward, reflect boundaries, move things forward. So I would say that our planning is based on creation of the new department as it stands now in terms of boundaries that we have. Like any time, we will always come back and revisit should there need to be a different type of approach in the future. But the main components of what those individuals do won't be changing, as I think Elizabeth talked about earlier, in terms of the role of strategic commissioning, making sure that we are developing neighbourhood health services in the way that the 10-year health plan set out, so that the functions won't be changing. So there may be some geographical boundary changes as you're describing.
Thank you very much, Tristan. I did say that Tris would be last, but we've now got hold of Sir Jim Mackey's letter. So we've got new inspiration, I'm afraid, Permanent Secretary. Yeah. So but new concerns as well as inspiration. So I'm going to ask Clive Betts to come in, please.
Which I hope the Permanent Secretary's got some inspiration for, because look, there's some really big stuff in here that ICBs are not going to do in future, are going to look to transfer out. I mean, we're talking about development of neighbourhood and place-based partnerships, infection prevention, often very different in different communities. Going on, it talks about other issues about good working relationships at local level, and really concerning issues here that the ICBs may wish to delegate to others, transfer to others.
And where's the funding for that?
Yeah, exactly. Is the funding going to transfer as well? Because councils haven't got loads of extra money that is going to apply to these functions.
Yeah, so for some of these functions, absolutely. If the function is transferring, quite often it's because it's been. If I think of the way that we manage and oversee quality, for example. Currently, you'll have quality oversight at a national, at a regional, at a local, it's ICB, but ultimately where quality oversight really happens and should happen is at a board level. So what we're trying to do is streamline, for example, what that quality function would do, so we're not doing it 4 times. We've got regulatory oversight and then it happens at a local level. So some of the functions will actually diminish in terms of how many times it's happening, because it's not adding value. It's an illusion of control where you have multiple places where the same things are happening. So effectively, yes. For some functions, so we are looking at some of the cancer networks, for example. The staff and the funding will actually transfer into the provider, and the provider will run that function and are a better place to do that. So I think in the letter it talks about the fact that these are being reviewed for transfer, and throughout this process we will make sure it's a safe transfer.
I mentioned particularly neighbourhood and place-based partnerships, infection issues. These are quite important, are they? Who is going to do these jobs? It looks like local authorities in the end, because it mentions them. But if you say the money is going to be transferred, that means that you're not going to make the savings that you are announcing, because some of that saving is going to go in transferring money to local authorities. Is it?
No, so when I say about money being transferred, you have programme pay and you have programme non-pay. So the cost of delivering the service. So if it's delivering patient-focused service, that transfers to wherever the function's going, but you don't need the overhead, the pay overhead to deliver it. So those are the examples I would give.
But you still need to do something, aren't you? I mean, people are doing send work in ICBs, this is mentioned as something to be transferred along with safeguarding and medicines optimisation. Who is going to do it?
I think all of them say, I think the letter actually says testing and exploring these functions to see where
Look,
best places
this is
should
really
happen.
confusing. I mean, we're at this stage and we're talking about cutting staff by 50% and we're exploring what might be done.
If I may, actually, I think what we've said is that those statutory functions, such as safeguarding, or said the very crucial statutory functions, won't be transferred to another body unless there is a place for them to go that is appropriate. And so, for example, with neighbourhood health, which we've talked about, it is at the moment a duplication across a local place, and you were rightly pushing us earlier on local place arrangements. So what we are saying is, if there is an appropriate other body to take those statutory functions, that will be part of the discussion that we will have locally. We will not be transferring those statutory functions until or unless that is the case. So if I give you an example, an integrated health organisation, certainly as set out in the 10-year health plan, may take responsibility for those particular areas because they're taking responsibility for the whole of the population. So what we are not saying is it's the same thing across every single part of the country, because that would absolutely defeat the point of it being local and as local as possible. And we're not saying that statutory functions would be transferred without the appropriate place for them to go.
That may be a helpful response. I think it comes back to, can you now set out much more clearly what is going to stay with ICBs definitely, what is potentially going to be transferred depending on local agreements, what may be transferred, what will be transferred, and what will be transferred with money and what without money. I think that this is all a bit mixed at present.
Happy to do so.
Because, I mean, looking at the penultimate paragraph of Sir Jim Mackey's letter, I mean, just to be absolutely clear, it says ICB will continue to work closely with local authorities as co-commissioners, and this may include building on existing arrangements for delegation or joint exercise of statutory functions under Section 75 partnership arrangements. Now, if you're going to transfer statutory functions from the ICBs to local authorities, presumably that will include also the resources to do so.
Yes. The reason I'm hesitating, I don't actually have Sir Jim's letter in front of me, which is...
I've just read it out.
Very unprepared of me. I have, of course, seen it and read it. I don't have it in front of me. We will be going through area by area to ensure the right arrangements are in place, should they be statutory functions transferred or not. But in many parts of the country, this is already happening. As in joint arrangements for joint commissioning. So very happy to come back to the committee in a bit more detail. What I would say, if I may, is that there will be different places taking different arrangements, so therefore we would want to perhaps use a couple of as example to show what that's looking like in different parts of the country over a different time period. I'm very happy to do that. Yeah.
Okay, well, I think we'll look at all the transcripts and everything you've said today. We may well want to have you back, I think, in the new year to examine some of these issues, because I think we do have an absolute duty to our constituents who are employed, particularly in the ICBs, to make sure that they thoroughly and comprehensively know what is being offered to them, and those that remain, what they're expected to do, and local authorities are able to plan with any new functions they've got. So I think there's still quite a lot that we need to unpick that we haven't unpicked today, but let's digest what we've heard today, and we may well want to come back to you. So thank you for that. We now want to move on to the main session, which is the whole vexed issue of clinical negligence, as I read out at the beginning. And to start us off with that, please, Clive Betts.
Yes, onto the main item of the agenda, which obviously is clinical negligence and the considerable costs involved in this. So how sustainable, given the current state of NHS finances, which clearly we've just been alluded to in our previous discussions, but the challenges about how improvements can be made going forward. But you've got major long-term predicted increases in clinical negligence costs. So they're almost going to absorb the productivity increases you're planning for when they ought to be going into service improvements. Are you happy with that situation?
If I may, firstly, I'd like to start, indeed, as Chair did at the start of the session, to recognise this is an incredibly sensitive subject, and at the heart of every element that we talk about, there's a human, as people who have actually undergone some potentially very traumatic experiences, and we wouldn't want to make light of that as part of any of the discussions that we have. And of course, ideally, we would want to stop people being injured in the first place. And I know that Aidan will come on to talk about that in terms of patient safety. We absolutely welcome the report on clinical negligence, and it's, of course, very well timed. At the risk of preemptively trying not to annoy the committee, I will say up front that the 10-year plan set out that, and indeed the Secretary of State asked David Locke, KC, to carry out a full review into clinical negligence, and which he has been doing, and he's advised with ministers. So I'm going to be unable to go into some of the detail, but I say that up front to you. The report, as you said rightly, sets out that the cost rise are complex, and I will ask Helen to go into more detail in some of both the cost, the breakdown, and also the work that has taken place over the last few years, led by Helen in a bit more detail.
Yeah, thank you.
Helen,
Good
please
morning.
come in. Yes, thank you.
Thank you, Chair. First of all, I also want to thank the NAO for a really thorough report. We think that's an important contribution to how we understand the drivers and how we also respond to the challenge of rising costs, which, as you've rightly identified, are putting pressure on NHS budgets and a significant cost to the public purse. As the report has found, the rising costs of compensation for claims of £1 million damages or more are a major contributor towards those trends, and those are the most seriously harmed individuals. Often claims associated with brain injury suffered in maternity care. Key features of those claims are that those harmed children require care costs for the lifetime, going on decades into the future, support for the family, aids in equipment, accommodation, and the calculation of damages for those cases is based on private care in accordance with the current law. The damages are also determined by court precedents. So, for example, access to innovative or novel treatments, which is another feature which has driven rising costs over time. I think the second thing the report rightly highlights is that there is an issue in relation to rising claimant legal costs, which are disproportionate for claims at the other end of the spectrum. Also, in many cases, serious injuries, people who've suffered harm in healthcare, but for claims valued at less than £25,000 for damages, the legal costs are very considerable and disproportionate, and those are all big issues.
We've all read all of that in the report, but we need to just to put it into context of Clive Bett's questions. We're currently spending this year £3.1 billion on clinical negligence, which one of our witnesses at our pre-hearing said equates to £350,000 per hour, every single hour, 24 hours a day in the NHS, and it's predicted to go up to £4.1 billion in the next 5 years to 29-30. So this is a huge cost to the NHS and a huge growing cost. So we know all of those drivers. The real question that Clive was trying to get at is what measures are you going to take to try and prevent that cost continuing to escalate at that rate?
Or at least, do you accept that measures are going to have to be taken?
If I can just highlight a few things that we're doing. So this is absolutely front and centre of NHSR's strategy, but of course we don't control the policy framework around the law, and we don't have a direct impact on frontline care. The most important thing is to prevent these incidents happening in the first place, so people aren't harmed. So it's incredibly important to us to feed back the learning that we see from claims back into the NHS at a national aggregated level, but also locally, to try to prevent the same things happening again. And that's incredibly important to patients as part of resolving their claim. The second thing we've been doing is keeping more claims than ever out of litigation. We've chipped away at what we call the litigation rate over a number of years to reduce the number of cases that go into formal court proceedings. We now keep 83% of cases out of court. They don't go anywhere near court proceedings. And it's at the litigated stage that those legal costs that I talked about earlier get very considerable. Things really ramp up when they get into formal processes, and that's also incredibly difficult for the patient, for their family, and for all the healthcare staff involved in those cases as well. We're undertaking more work to reduce our own legal costs as well. So the NAO pointed out that we go out to tender for legal firms to get the best value for the NHS and also the best quality of advice. But as we take more cases out of litigation, we're also using that opportunity to bring more work in-house so we can further reduce that commercial legal bill. And then perhaps the final thing to highlight is that in relation to the huge data set that we hold, which goes about 30 years on the causes of harm in the NHS, we're starting to explore technology to really mine that data in a very detailed way to see what it can tell us both about the causes of those claims, but also about how those claims are made up in terms of damages. And that more in-depth information will help support the department's wider work in relation to policy.
And just in terms of the direct answer to the question I think that was posed, building on that, is yes, the government's very concerned about the increasing liability as set out, and that is one of the main reasons that our Secretary of State asked David Locke to carry out his review.
Good. We have a common starting point at least. Rupert Lowe, please.
Thank you, Chairman. Well, it does appear that we have a major problem here. And it appears that not only are more people suffering the consequences of medical malpractice, but the downstream costs of dealing with that are obviously rising. So I think we've got to look at the upstream and the downstream. The legal costs are a downstream result of medical malpractice within the NHS, within your department. So I've got a question, I think, for the Permanent Secretary. I mean, do you agree with me that good data is the basis on which good decisions are made rather than bad decisions? That's how I've always run my businesses. I mean, do you agree that's a logical summary of how people make good decisions rather than bad decisions?
It is entirely how we would hope to do so, yes.
Okay, well I've asked a lot of questions through my parliamentary office. So number of GP registrations by non-UK citizens, no data. Number of illegal accessing healthcare services, no data. Cost of treating those with no right to be here, no data. Nationality and immigration status of NHS users, no data. Patient category F breakdown between illegals and visitors, no data. Cost, monetary and time of translation and interpretation across the NHS, no data. On questions about standards of English and the health service, I've asked what steps you're taking to ensure overseas recruits can speak English effectively. I haven't had an answer. So I'm interested, my first question is, I'm interested to know, if you don't have this data, what do you think are the reasons these clinical negligence damages are increasing so much at the front end, not the legal end? So why are we getting these cases
with your permission,
increasing?
if I can hand over to Aidan as the doctor. Thank you.
Yes, please.
Thank you.
Thank you.
So, thank you. I think the first thing to say is that clearly we work all the time to drive down cases of harm. There isn't evidence that those are increasing, to be clear, and in fact the level of claims has not been increasing for a while now. We are taking considerable efforts around patient safety and levels of harm, and believe we have had impact on that over the last period of time. That has been through a mechanism of the patient safety strategy, which was the first strategy for patient safety that the NHS has had and was published in 2019. It was published just before we had a pandemic. Nevertheless, we have made good progress with that work, including through the pandemic. And while it is difficult to estimate, we estimate that we are avoiding 1,000 deaths a year that would have occurred had we not done that work fundamental piece of work around how we learn from the system, how we investigate, how we involve families in those investigations far more, and patients, how we report and how we learn from that reporting. And we have a massive database, to your right point about data. We have a database with 3 million incidents going into it a year from which we're learning. To be clear, to reassure you, most of those are no harm data points. So something has gone awry, but there has been no harm as a result of it, and that's about 70% of the data we see, and then another significant chunk of it is low harm. So it's the minority of those reports that involve either moderate harm, serious harm, or death. But we're learning all the time from that. We have made reductions. That is estimated to save UK PLC, not necessarily the health system alone, hundreds of millions a year. But there is far more to do, and we continue to do that, and we continue to prioritise programmes around that. One of the difficulties when it comes to clinical negligence is there is not... One would assume if you reduce that, you would see a reduction in litigation, but there is a difference between where we see the majority of the harm, which tends to be in older populations, and who litigates. So actually there isn't a direct connection between the two, and the areas where we see the highest levels of harm are not necessarily the areas where we see most litigation, although we aim to learn from litigation and clearly wish to see it reduced through the reduction of harm. I hope that's helpful.
So well, thank you for that, yeah. So can you explain to me then, I mean, I've had literally hundreds of NHS whistleblowers. You probably know I've set up something called Restore Britain. We've got our own whistleblowing line. We've literally had hundreds of NHS staff whistleblowers, I mean hundreds, who've contacted us about the lack of English language causing issues, as well as foreign staff not holding appropriate skills and qualifications. Now, these people, these are doctors, they're nurses, they're midwives, they're managers, they're surgeons, they're everybody within the NHS. It's not just one subset. And what they're frightened of actually reporting it to the NHS for the fear of the wokerati who run the NHS now, their fear of reprisal, so they've come to us. So, I mean, I'd like to know, you must accept the fact that we need the data. So what data do you hold, basically, on the correlation between foreign nationals and medical malpractice taking place within the NHS? You must look at all this data. You can't fear being called racist or anything else. We need raw data for the taxpayers' benefit and also for the patient's benefit. Surely we must drill down and we must find out why this is happening.
We've got the message there. Let's let Aidan answer that.
Well, I think, so I wouldn't want to be considered part of a wokerati, but I mean, we are very animated about issues around inequalities and so on. And we are hand reading, for example, and to the point about digital, with machine learning, we will get far more data from those 3 million incidents that I'm referring to. But we are hand reading the death and severe cases, thousands of those a year. And what is not coming out of that is that there is an issue around people who've come from abroad and language and communication. There is undoubtedly communication issues around inequalities in harm, and we know that some groups are affected by harm more, partly because of communication, and communication is undoubtedly important in safety. But what we're not seeing from those reports we're reading is some of the things that you're describing people whistleblowing to.
You disagree with these whistleblowers?
So I'm not disagreeing with whistleblowers because I haven't spoken to them, and it's important that people feel able to speak up. And one of the things that we are very focused on is that the concept of psychological safety and people being able to step forward and talk to us about these things.
But can I just say that if you've got cases of whistleblowers, there's a proper procedure to deal with those, and if the NHS don't know about them, they can't do anything about it. So
my whistleblowers, Chairman, they're not reporting it to the NHS for fear of reprisals from...
There are systems for them to do so through freedom to speak up, which are I know people are very concerned about themselves when they whistleblow, but there are very safe systems for people to speak up, and they do not suffer any harm as a result of doing so through our freedom to speak up system.
Clearly these people don't agree.
And indeed we would encourage anybody who has any concerns to come forward and raise through the processes that Aidan sets out.
To be fair, Rupert, if the NHS don't know about them, they can't do anything about it. So I think we perhaps need to set up some offline meetings to see how we can deal with this.
I'm happy to do that, Chairman, but I do think the NHS needs to improve its whistleblowing line and make sure people do feel comfortable to come forward. They wouldn't come forward to Restore Britain's line if they thought they were going to be treated fairly by the NHS whistleblowing line. I think I venture to suggest it's actually a requirement for them to improve theirs. I'm very happy to share the data we've got.
Let's take that offline. Neil.
Thank you very much, Chair. And before I start, I should declare a number of interests in this subject. So I hold a practicing certificate with the Bar Standards Board. I am an associate tenant at number 5 Chambers, and my area of practice included clinical negligence and personal injury law. I have previously been a member of the Personal Injury Bar Association and sat on their executive. I have previously been a member of Action Against Medical Accidents. In addition, I am registered with the GMC, but I no longer hold a licence to practice. By virtue of having more than a decade in medical practice, there have been cases of which I've been involved that have involved litigation of some description, although not personally against myself. And I'm both a member of the Middle Temple and the Royal College of Surgeons. So I've got that off record. I'd like to talk, and I direct my questions to Ms Vernon, because you've already raised the challenges for government around the cost of damages and the fact that a lot of that is set through precedent or the Judicial College guidelines, etc. I wonder if you could set out what extent the rising cost of clinical negligence damages, opposed to overall costs at this stage, are within the government's control.
Yes, thank you, and it's a really good question, and in fact the NAO makes a recommendation that we should try to, through data analysis and through soft intelligence, establish what's controllable and what isn't controllable, both within NHSR's control but also what's attributable to the legal framework. A lot of the things that are in the sights of our strategy are things that we think are within control, so we can do more to keep cases out of litigation, we can do more to reduce the stress on families of going through those cases and of claiming compensation, and we can do more to do things like make interim payments at an early stage on brain injury cases, and that's why we've introduced the early notification scheme for obstetric cerebral palsy that's referenced in the NAO's study. What's more difficult is the legal framework that surrounds recoverability of damages, which, as you all know, provides that the individual should be entitled to compensation which will put them back in the position that they would have been had they been uninjured. So that's why people can recover their care costs on a privately funded basis. That's why they can recover loss of earnings, sometimes with reference to family members. That's why they can recover expensive aids and equipment and get accommodation needs met too. And those are all things which are very important to harmed individuals and their families. So we need to do more to dissect that problem in pounds and pence so that we can inform the impact analysis that the department would no doubt wish to do in relation to any policy solutions. But certainly there is an element, as you rightly said, that is controllable, but also an element which relates to the current legal framework.
And just picking up on some of those threads around policy decisions, and it's always a difficult concept to talk when somebody's been harmed as a result of a medical accident around capping damages. Now, there are some damages that are obviously less cappable than others. So the cost of accommodation, for example, there is a certain value to that. But in terms of general damages opposed to special damages, does your department have a view on looking at capping damages in respect of that? And if I can piggyback onto that, you've mentioned the cost of private healthcare. Damages are set on the basis that that healthcare would be recovered on a private basis, or the treatment would be on a private basis. Of course, a number of people will receive that care on the NHS, which in effect is getting a double reward. It's of course appropriate that these individuals are put back to where they should be as best as they can given the circumstances, but it does seem somewhat perverse that you are getting access via the NHS as well as effectively being able to hold on to the sums that you could have spent on a private basis.
Yes, and you're right to raise that. It's an incredibly important issue, and it goes to the heart of how damages for care in particular are awarded, and they are, as a broad estimate, about 60% of the very high value settlements for damages relate to those future care costs. The current law provides, as you say, that you can recover those on a privately funded basis. I wouldn't want to talk to the policy solutions that ministers might be considering. What I can say is that other jurisdictions have done it differently. So, for example, in Australia, which has broadly speaking a tort system, although it's different state by state, they've certainly introduced caps for things like average care costs, care rates, what's considered to be reasonable. They've put caps on loss of earnings recovery, so that's pegged to average loss of earnings, rather than with reference to the evidence of family members, and various other sort of caps and limits that have been applied. Other jurisdictions do it very differently. So the Scandinavian countries, which have avoidable harm systems, they work on the basis of a top-up of state available care, so that there's no duplication, and indeed damages are minimised because it's an additional cost over and above what that individual can access from existing state services. But it's not really as straightforward as, I suppose, of translating one system into another. England is very unique, and I think whilst we have a very thorough understanding with the department of what the drivers are and what some of the solutions might be, decisions on that will ultimately be for ministers.
Just picking up on that, because another potential area that costs may be escalated is the lost years claims, and there's a case going towards the Supreme Court at the moment of CCC in Sheffield Teaching Hospital, which is challenging the case of Wiseman. What assessment has NHSR and the wider DHSC made in terms of the impact, were that judgment in favour of CCC, would have on the ongoing expenditure and the weight of clinical negligence costs to the
Neil, could you just for the record just say what CCC is?
Sorry, CCC is the anonymised name of the claimant because it is a case involving a child brought against Sheffield Teaching Hospital.
Thank you.
Thank you. That's it's a significant case. It's been in the appeal courts for a while now. I think it was being heard at the early part of this year, so we are currently awaiting judgment from the Supreme Court. It's an interesting case in its own right because, first of all, very seriously injured child, obviously some very significant needs, and it's a very sensitive case for that reason, so I wouldn't want to go into the detail. It's just to mention as well, before I get to the assessment on lost years, this is the kind of case that illustrates the level of care that's required. So in this case, we've got 2 carers round the clock, and the judge awarded care on that basis. We've got home hydrotherapy and a number of other quite expensive interventions given the severe nature of the disability. For lost years, we estimate that if successful, there will be about £800,000 addition on each case. And we have made that assessment. It's an estimate, I have to say. It depends on the different variety of cases we get where lost years might apply, but that's the kind of magnitude of the impact.
And could you just tell us for the record how many cases there are in that category?
We settle on average around 120 to 130 brain injury cases every year involving children. And the lost years case that you're referring to relates to children because it concerns their lost income beyond their expected life expectation, if that makes sense. So for adults that can be recovered because you can evidence it, but for children it is clearly more difficult.
Thank you very much. Dr. Neil, any further questions?
One further, if I may, and moving slightly away from the damages, but in terms of overall costs. What actions are being taken to reduce the overall costs of clinical negligence? And I open that up to the entire panel. So,
as I said up front, the government recognises the cost of clinical negligence and how it's foreseen to grow over the next few years, and that's why it's, the Secretary of State's asked David Locke, KC, to review and come back with recommendations in terms of addressing future. And as I said at the beginning, I can't go into much more detail at this stage.
Well, we will probe some areas where you might think about changes, even if you can't tell us that you're actively considering them or not. What we will during the rest of the hearing. Anna Dixon, please.
Yes, I'd like to come specifically to maternity and obstetric care, given what obviously the panel have said in your opening remarks and the NAO report puts very starkly, that these are obviously the higher value cases and account for a significant proportion of the increase in claims. And obviously, as a constituency MP, I've suddenly had casework of individual who has had a brain damaged child with very high need. And obviously, it's important that those families and children are getting financial compensation to be able to support them with their medical and care needs. But mindful of that, I'm keen to know, please, Helen, what action NHS Resolution are taking to just try and manage the cost of maternity claims?
Yes, and as you rightly say, maternity claims absolutely dominate the costs that we referred to earlier, because of those very high value cases with needs going on decades into the future. It's a strategic priority for us. It's remained so certainly for the last 6 to 7 years. Underpinning that, we've got two main schemes. The first I referred to earlier is the early notification scheme for obstetric cerebral palsy cases. That's quite innovative. It's certainly new. It's not being done anywhere else. And how it works is we ask because we had an issue with time lag in relation to those cases of an average 11 to 12 years, it was impossible to derive learning from those cases or to get assistance to the family early on. So what we now do is ask to hear about those cases right from the start. So we hear about them from the MNSI who initiate the initial investigation right from the start, so we can accelerate the investigation into legal liability with the family's consent. We can identify whether or not they're likely to be entitled to compensation. If they are, then we can get them some early interim payments so it can support with those really important early year needs, some of those aids and equipment that might be make all the difference to a family in the early years. We can get the learning out of that case and get it back to the trust as soon as possible, as well as aggregate it up nationally. And in due course, we hope it will also reduce costs because it will reduce the inflationary impact on those very high value losses. We're having that evaluated at the moment with the support of the Government Actuaries Department and This Institute. We hope to be able to publish the evaluation in the new year. But if it succeeds, it should both make the experience better for the family, but also reduce the costs in the longer term.
Can I just establish, because we had in our pre-panel around victims of car crashes or and the view there seems to be to get rehabilitation in very early as intense as possible, because the more appropriate and effective treatment you can provide somebody, it could give them improvements which reduce their sort of lifelong need. Is that what you're describing? Are you sort of suggesting that even before this goes anywhere near litigation, there is support going on to try and sort of rehabilitate and treat the child?
Not quite, almost.
No. Okay.
If a brain-injured child is usually undergoing NHS care in any event, particularly in the early years, so there will be those state support systems in place in any event at that time. What we normally make interim payments for are some of the things that might assist the family in the early years. It can even include things like counselling for the family, so that and some interim care needs as well to ensure that a care regime can at least be up and running to enable, for example, the family to go back to work or to provide support which is not as intensive as is sometimes required from families in those early years. So not rehab as such, but it should help with the ongoing support of that child, because we're getting in much sooner than we've been able to do historically.
So, Professor Vernon, if I may, as you may know, I did some work many years ago at the King's Fund on an inquiry into safer births, and at that time it looked at many of the historic reports about what needed to change to reduce harm in maternity services, and it said there are far too many recommendations and none of them are being acted on. This is what needs to happen. I fear that with the AMOS review, we're going to sort of find ourselves in a similar position where we sort of say, another decade has gone by, we've had many reports, many recommendations about things that need to do to make maternity safer that we haven't acted on. So what, from the point of view of, clinician leadership, we have evidence from the Royal College of Obstetricians and Gynecologists, which points to some of the changing demographics around older women giving birth, higher levels of obesity, diabetes, etc., that's leading to higher levels of complication, more medical complexity. What do you think, from the point of view of a sort of medical leadership, needs to be happening to try and reduce both the number and severity of claims in this area?
Okay, so this is a highly complex area, so stop me if I go on too long, because I probably can on this. But
I'll leave it to the chair to stop you, because I'll no doubt...
So first, on the AMOS review, which we're waiting for, and we're expecting the final review, that will be next year. I think very sensibly Baroness Amos is aiming to try and provide a new sort of version of recommendations that takes into account all recommendations so far and tries to synthesize those into one report, which I think is really helpful. There have been a lot of recommendations, and we are expecting more recommendations, for example, from Nottingham. But that doesn't mean we're waiting for that to act. And I think I'll come on to the maternity issue. You mentioned maternal complexity in a second. But on brain injury, I would divide it into two areas. So there's work on preterm, as in premature babies being born, and what they need in order to reduce the levels of brain injury. And that is slightly different, and I'm not an obstetrician, to be clear, from term injury. And one of the things we've seen is that term brain injury, if you look at early data, including MNSI's own data, and I have a graph here, that has actually been reducing. So referrals for term brain injury have been reducing, whereas preterm's been a bit stuck. But our own work on preterm and within safety, we've been responsible for some of the work around that, of best practice bundles and making sure they're more consistently applied. We estimate to have reduced cases of brain injury in preterm by about 500 or so a lot. That is not the group, actually, who mainly litigate, as I understand it, and Helen may correct me on that. Most of the litigation is around term brain injury. In that, there's been a lot of work to understand what the best impact would be to try and drive that down, which broadly falls into two main categories. One is fetal distress, and you may be aware we have been very keen to have a suite of early warning scores around deterioration for all age groups. So the panel may be aware of the National Early Warning Score, which is for adults, and the work we've been doing on Martha's Rule around that. We also have a maternal early warning score, MUSE. We're not great on acronyms, I have to tell you, and a neonatal early warning track and trigger tool, NEWT. And we are now developing fetal deterioration monitoring and distress monitoring as part of a program called ABC, which is Avoiding Brain Injuries in Childhood, which is being rolled out as we speak, which looks at what can be done around reducing levels of fetal distress, recognizing fetal distress and intervening earlier, but also managing the impacted fetal head, which is another issue of the baby gets stuck. Do you want me to cover the...
Just thinking that may be getting too technical. I think
it may be, and I was going to stop at that point. I just cover the maternal thing,
Thank you.
Which is there is an issue around the fact that we now have older mothers with greater levels of obesity, and they are risk factors for maternal harm, if you like, and maternal mortality. So we have struggled with reducing maternal mortality in the face of that increased risk, and that impacts on things like that one of the the highest cause of neonatal death is congenital abnormality, and one of the causes of that is older mothers.
So just briefly on the ABC, we heard in the pre-panel...
I think we don't want to get too much. We've had quite a lot of detail. I'd like to keep to the top levels.
Okay.
Please, Anna.
Okay, well, it was really just the learning from Victoria, Australia. We heard, I think, really quite dramatic figures, about 50% reduction there in claims and cost frequency. And the idea that if all English units could achieve the same outcomes as the top 20%, not only would there be 116 fewer infants born with cerebral palsy, but this could reduce up to 1 billion. So just a very brief answer, if I may, is that the purpose of the ABC
It
programme?
is in part, and ABC has been in part developed by an obstetrician called Tim Draycott, who developed the prompt training, which he introduced in Victoria, Australia. So he's had some influence in Victoria, Australia, as well as the influence he's having here.
Okay.
Thank you.
And have you...
Oh, sorry, there was a slightly second part, which was to go into other specialties. Should I just briefly pick that up,
Yes,
Chair?
please.
Yeah, so the other specialties, obviously, where more progress has been made would be surgery. Again, long-standing WHO programmes, surgical safety checklists and everything. I guess it's, what's the learning? What's led to those reductions in reducing surgical claims? And how are you applying any lessons from that to other areas, if at all?
I think...
Should I add something to that?
Yes,
yeah. I mean, we've done a lot of work with the Getting It Right First Time programme, who is a programme part of NHS England, and bringing claims data together with all the other metrics that exist in the NHS in relation to these areas, creating litigation packs, and then sort of really drilling down into what the causes of those claims are. So for surgery, a lot of the issues are around things like consent and infection control, and we did some specific work with Getting It Right First Time on training on consent, going out using the boots on the ground that Getting It Right First Time have to really connect with clinicians, use claims as an illustration of how these things can go wrong and the consequences of that, and to really help with those local safety interventions that need to happen to prevent these things going wrong in the first place. Whether or not there's a cause and effect between that work, I couldn't say. It hasn't been evaluated, but it's certainly encouraging that that specialty has shown a reduction in claims following that piece of work being taken out.
Right, we need to keep this fairly tight.
Yeah, the only other areas where the data seems to be going in the wrong way are mental health, radiology and paediatrics. So I guess, anything specific on those as to why and what you might seek to be doing. Again, it could be from either Helen or from Professor Fowler.
So on the surgery thing, I'm a surgeon, so I'm bound to want to talk about it. But I mean, there's a lot that's been done around, for example, the checklisting and so on. We have to be a little bit cautious in attribution because, for example, Scotland published their data on it, and the decline in mortality came before the programme to introduce the checklist. So sometimes things are called out as a cause of, and it's not clear they are. So there have been a number of programmes in surgery. I think it's more difficult to say why it's rising in other areas, other than to say that we know there is an increase in demand around mental health, and we know that there are more diagnostics done in radiology and there is more interventional radiology, and it may be that those are drivers, and we'd need to look at that in detail. You may have more information.
If I can add to that, in mental health specifically, there have been some big, quite high-profile group actions. So disproportionately, the addition of those group actions has meant that there's been a high percentage increase. But many of the factors that
they relate
to
deprivation of liberty, or what were those? What was the harm?
Related to certain secure units, and probably without going into too much detail, they involve multiple claims arising from the same events.
Okay, I'll leave it there.
Could you just, turning to those tables that Anna was just talking about, really, these various different disciplines that are going up and down. One that did surprise me was the number of cases rising on figure 7 in radiology. Is this to do with misdiagnosis from the radiology, or is it the actual administration of radiology?
Misdiagnosis, generally.
So is that something that AI would come to our aid potentially?
Potentially, yes. In some areas more than others. For example, there's good AI reading of mammograms as an example. So it's working better in some areas than other areas. But I don't have a huge amount of detail on the specific cases. I think the other thing around, in general, safety is tracking. So reports going missing, that sort of thing. And I think we are looking now at a program of getting digital systems in, and this applies in primary care, for example, in diagnostic tracking, where people get lost somewhere along a diagnostic pathway, and that's recognised in a study by a GP called Tony Avery. Digital systems can support us in making sure that we track patient pathways better, so that if you go and have a CT scan, the report is seen by the right person and acted on. Or, for example, we see cases where somebody comes into an emergency department with a chest injury and they have a chest x-ray, and people look for signs related to the injury but don't see the lung cancer that's an incidental finding, and that's tracked. So these sorts of cases that have arisen over time, we've got to get better at tracking, I think, on those.
That's very helpful. Well, we've got a lot of ground still to cover, but I think what we'll do now is we'll take a break. The clock is currently at 11:27. If we could be back here by 11:35, because we've got a lot to get through. So I suspend broadcasting, and we'll be back here then, hope. I'll resume the session, and starting us off with that is Tris Osborne, please.
Thank you very much, Geoffrey. So I'm going to specifically talk about the general practice scheme, so looking at figure 1.15. Obviously, my colleagues have dealt with the element at the medium to top end, but I'll be looking specifically around GPs. The new CNSGP scheme was introduced in 2019. There has been an indication that numbers have significantly risen from 273 to 2,914. That is a major increase in that period of time. Now, clearly, there's a move of indemnity now back onto the NHS. It says that the figures are going to be stabilising in one breath, but then clearly to continue to increase. Have you done any modelling around these numbers, first of all, around where the expectation will be? Are we due a stabilisation, or are we due an increase?
Yes, thank you. And the scheme insisted on 1st of April 2019, which means that it related to incidents occurring after that date. So I think, as you alluded to, that experience will grow over time. And the increase that from a few hundred in the first year to what is now almost 3,000 in the current year is broadly as expected. We have a reserving and pricing committee which monitors experience on a regular basis and receives input from our actuaries who work with us to model both what that means in terms of cash flow, but also where it might be going in the future. The challenge we have with modelling where this is going to go for the GP schemes is that we do not have the complete historic experience to hand. And the reason for that is because the historic claims sat, broadly speaking, with 3 of the medical defence organisations. So they were not on the NHS balance sheet, they were elsewhere. And only 2 of the 3 MDOs participated in the transfer of those historic liabilities. So we've got partial experience of the past, but not complete experience. We expect to have much more information as the scheme moves on, and certainly in 10 years' time, although that seems very distant, we hope to have a much more complete picture than we do currently.
Can I ask a number of follow-ups? So just on the modelling, are we predicted over, because obviously 10 years is a long time, as you've correctly stated, where are we predicting the numbers to be? Because obviously it has gone up from a smaller number, you would expect that when the scheme is implemented, but it has gone up by almost 100% in some cases. Yes. That's a significant increase in 6 years. So where are we modelling this over the next 5 to 10 years, for instance?
And perhaps to correct what I said earlier, we hope to have more information. We don't have the figures 10 years in advance. We just know that we'll have more experience to be able to produce those figures. We do make estimates 5 years in advance. I don't have those to hand, but I can certainly make those available to the committee after today, if that will be helpful.
Yes.
Thank you very much. It would be helpful. If I can follow up then around transparency. Clearly on these low volume cases, we know that there is a lack of transparency around claimant compensation. The NO reports that. But we also know that the legal costs are 3.7 times higher than the damages awarded. That's on the table on the back. So there is a question of sustainability here around these low volume, these high volume but sort of low end awards. Is there a clearly you're going to be looking 5 years in the future. Is there a concern around this this lack of transparency, especially around legal fees and the engagement of legal practices?
Yes, it's a really important point that the NAO raised. I think there's 2 separate things in your question. The first is the disproportionality at the lower end. So I think it's 3.7 to 1 for cases resolved for less than £25,000 in damages. So that's one issue. The other issue, though, that the NAO have captured in one of their recommendations is that in addition to what's reported in our accounts, the lawyer representing the patient can also recover an element of their fee from the patient's damages. And that's not reported in our accounts. It's largely invisible to us because it relates to the retainer, the commercial arrangement between the patient and their lawyer. And the NEO has recommended that we work with the claimant legal market to see if they are prepared to share more of that information in a more transparent way, so we can get a better indication of the true cost.
Can I ask where clearly, the Permanent Secretary, you said that this is part of an ongoing process, that there's stuff sitting with the Minister here, but is there engagement around this particular issue, around getting that transparency much more clear to ensure that we can, because these cases have increased significantly over the last couple of years, they represent an increasing proportion of volume cases, so this would appear to be quite a reasonable request, if not more than that, for these organisations to give us that information.
Yes, I wouldn't want to go into detail of the review that David Locke KC is carrying out, but I would expect him to be covering all aspects.
Thank you.
Can I ask you, Helen, in our pre-hearing, there was a certain amount of work being done, particularly on these under 25,000, and to just put it into context very, very clearly, for a claimant claiming 25,000, the legal costs are 100,000 or 75,000, 4 to 1. I mean, that's the nonsense of the system. Why is it that we were told the Civil Procedure Rules Committee has actually put all its work on hold, so there are no ongoing investigations into the sub 25,000 category?
So that relates, the work of the Civil Procedure Rules Committee relates to the consultation which was run under the auspices of the previous government by the Department of Health and Social Care on fixing costs for those lower value cases. Again, I can't talk to the policy. I believe David Locke's looking into that. What I can say, though, is that we, working within that framework, which is essentially that lawyers can charge an hourly rate, we try to minimise the costs that are incurred by the other side as much as we possibly can, by keeping things pre-proceedings and by trying to resolve the claim through non-adversarial means. But I don't know if the Permanent Secretary wants to comment on the policy.
I wouldn't want to go into any more detail at this stage.
What's the timing of the David Locke report?
The review is currently with ministers. It's currently with ministers.
Right, okay, that's very helpful. Let's just then move on, please, to Sarah Green.
It's more of a follow-up question, really, Chair, on the area of where costs of clinical negligence cases, the legal costs appear disproportionate, especially when it comes to claimant legal costs. And it's more of a follow-up, if I may, to Ms Jones, around what the department's doing to address the increasing amount of NHS funds being paid to clinical negligence lawyers rather than those individuals who are owed compensation.
At the risk of repeating myself, the rising costs of clinical negligence have been taken incredibly seriously, and as I said right up front, absolutely welcome the focus and the areas that the NAO has been looking at. The Secretary of State commissioned David Locke to carry out his review covering all aspects of policy, and as I said just a second ago, with ministers at present. Is it perhaps worth Helen explaining some of the work that's been done over the last couple of years to kind of look at these costs in more detail and the actions you've taken?
Yeah, absolutely. I mean, there's two things. Firstly, defence costs. So the lawyers that we procure are on fixed and capped rates. And you'll see from the NEO's report, we've broadly kept the increase in those costs level with general inflation as a consequence of that. And then we hope to do even more there. We've got a procurement coming up, and we're also trying to bring more work in-house so we can do it at a lower cost. The second thing is, in relation to keeping things out of litigation, there's not just a positive benefit for patients and their families and the healthcare staff are involved in those claims. There's also a positive financial benefit. On average, it saves £96,000 in claimant legal costs to keep something pre-action rather than allow it to go into litigation, and that's on top of the court costs and the additional costs that we incur with our own lawyers as well.
Follow up on that, if I may. Is there anything you can do as in your organisation to improve the transparency around the additional legal fees that claimants pay out of their compensation? So there's no clear figure attached to that, but is there anything you can do to increase transparency on that?
And we hope so. It's a welcome challenge from NAO in the report, because it shines a light on the issue. It gives us the opportunity to debate that with the claimant legal market, and we've increasingly worked more collaboratively with claimant lawyers as well, because we do have a shared interest in making sure that we prevent these cases and also deliver the right sort of compensation for their client. So we've already actually, on the back of the NAO's report, started some conversations with the main claimant law firms to ask them what they're prepared to share to do more of in that area on a voluntary basis.
Could you write to the committee and give us a bit more detail on that? Because I think that would be something we'd be quite interested in.
Yes, very happy to.
Thank you.
Thank you very much. Dr. Neal, please.
Thank you. And there's a huge discrepancy, having done both claimant and defendant work, in terms of the rates you get paid. And so I'm pleased to see that that's going to be part of David Locke's review in terms of fixed fees. Can I just turn on to the point of expert evidence? Because these cases hang on the expert evidence, and yet often that's not disclosed until some way down the process. What engagement has taken place with the Ministry of Justice and with the Civil Procedure Rules Committee about looking at the pre-action protocol for clinical negligence disputes to see whether there is benefit in having early disclosure of the expert evidence, because that often may resolve issues without stacking up legal fees. It may mean that ADR can take place, alternative dispute resolution, at an earlier stage. And what engagement, perhaps from the Permanent Secretary, has your department had in terms of that with other departments across government?
Thank you. As you rightly point out, this is a matter for a cross-government issue, and working closely with our colleagues, the Ministry of Justice. I am going to refer back to my previous answer around making sure that the costs, the way this is handled, looking at all policy aspects, and not going into specifics of any particular one covered in David Locke's review. Is there anything particular?
Yes, I can add to that. I'm really glad that you asked the question, actually, because it's an area that we've responded to a number of times in consultations from MOJ on things like the pre-action protocol. We would be really keen to shift to a position where there is earlier disclosure of expert evidence and perhaps even opportunities for joint expert evidence in the pre-action phase. Aside from policy solutions, which of course are not for us, that's an area that we're exploring actively with the claimant legal market to see if we can do that on a voluntary basis. It's more difficult, I guess, for liability, but certainly has much more potential for things like quantum, for things like care experts, where there is often very little between the two experts who've been instructed by the NHS's lawyers and the lawyers acting for the patient. So I think there's huge potential there, and it's certainly something we would like to, again, move towards on a voluntary basis if there are not other solutions forthcoming.
And another issue that affects the NHS's budget is the fact that you have a QOC system, so a qualified one-way cost shifting. So claimants who are unsuccessful in their case are not liable to pay the costs of defendants unless there are exempting circumstances such as fundamental dishonesty. There is a risk, is there not, that this leads to perhaps claims that have relatively poor prospects or no reasonable prospects of success being pushed longer than they perhaps should be. The cost then is borne by the NHS. Is there any thought, again it would be cross-departmental, on whether we should be re-looking at QOCs as a principle, even if it's deposit type orders that may be put forward by judges where on the initial assessment there are very poor prospects for a particular claim?
I mean, you rightly say it sort of heightens the risk, but QOCs was part of a balanced set of reforms that was introduced as part of the LASPO Act back in 2013. Again, it's an area for certainly for consideration, but in the meantime, that doesn't prevent us challenging the bills with which we're presented by claimant lawyers for the work that they do, which we do on a regular basis. And last year we saved over 138 million on claimant legal costs, raising those challenges.
And at the risk of indulging the Chair, one final question, and I'd like to bring in Professor Fowler on this because it involves patient safety. Inquests now are routinely done under a CFA when representing families, on the presumption that if there is a successful clinical negligence claim that arises out of it, those costs will be recoverable. That, of course, does change the context of the inquest from an inquisitorial process about how things went wrong and what can be learnt from it to perhaps more akin to a satellite litigation. I wonder whether you think that model of CFAs for representation at inquests undermines the patient safety element and the learning exercises that can arise out of them.
Not something that I really had much to do with, so it would be very difficult for me to comment because I don't know the detail of the particular issue around coroners. Obviously, it's the sort of thing that our medical examiners would be more familiar with. So it's something perhaps the National Medical Examiner would be.
It's a very important issue that Neil raises there. Permanent secretary, could we have a note on this whole area? I think it's a sensitive thing, these inquests.
Well, we can certainly look at it and write back.
Thank you very much. Neil, anything else you want to raise? You're making some really excellent points. Right, if not, let us then move on to Tris, please.
Yeah. So my next series of questions will be around alternative dispute resolution. So specifically figure 13 and the 3.12 and 3.13. Alternative resolution is being applied in parts of the United Kingdom already, specifically Wales, where we have an alternative redress scheme as part of the NHS Redress Act 2006. Without going into too much detail, because obviously that might be something considered in the David Locke review, and I don't want to get the sort of standard response back, have we been looking at alternative dispute resolution approaches similar to those that have been introduced in Wales?
If I can comment on that, we do a huge amount of alternative dispute resolution, as the NAO has acknowledged in their report, but it's not a one-size-fits-all approach. You have to ensure that you're offering the right thing to the family in the right case. So we were the first body of our kind to set up a mediation panel, which has been running for some time. We do considerable amounts of mediation, which often is an opportunity to bring the clinician together with the family to provide an apology and explanation and reconnect and rebuild that damaged trust after an incident. And there's a variety of other things which you'll have seen have been set out in the report, in the table that you've referenced. I think we would like to do much, much more, of course, and keeping things pre-action is definitely the opportunity to do that. The Welsh model is interesting, but it also has its challenges, I think, because a lot of the resolution is devolved to the local health body, which can have benefits, but can also mean there's a risk that there's inconsistency in decision-making, potentially. I'm not saying that happens in practice, but it's certainly a risk to be borne in mind.
Just one further follow-up, and then I'll pass to my colleague. In other jurisdictions, they have an ombudsman-style approach for a redress scheme for the lower value. So clearly, they have a dual-track approach. Again, has that been... Wales doesn't have that, but has that approach, looking at other nations in Europe and others, also been considered? Because it would seem sensible, given the ratios of legal fees that we have been previously talking about, to be considering those approaches.
And again, I wouldn't want to get into the policy side, but I'm aware that there are ombudsman-style approaches in other jurisdictions, like France, for example, I think has a similar approach. But it's not directly translatable across into England necessarily. The Ombudsman in PHSO obviously has very different powers, a very different remit, and a very different way of looking at cases. And so you would need to fit that together with what we do, which is to essentially get to the right answer as quickly as we can, but using a tort threshold for recoverability. So it's not a like-for-like translation. The other thing to bear in mind in relation to systems like the French system is that moving to a different style of approach and sometimes a different threshold for damages can also mean that you're opening out compensation to more people. Now that can be a good thing if you are compensating more people for things that have gone wrong in healthcare, but it also has cost consequences that would need to be very carefully modelled and weighed in the balance against what that money could potentially do for other safety initiatives.
Just a last follow-up, sir. You mentioned the torts legal system that we have. Again, without getting into the realms of policy decisions, do we think that that is a financially sustainable model at this lower end, around sub 25,000?
And I think the issue with the sub 25,000 is not per se the tort system so much as the basis on which costs can be recovered, which is, as we talked about earlier, is on an hourly rate basis, which is very different to other areas of personal injury like motor and employers and public liability. So I think that the two ends of the spectrum, the very high value severe injury end and the lower value, but nevertheless quite significant in many cases, high cost end, possibly require a different set of options. But again, I wouldn't want to sort of talk to policy in those areas.
Thank you.
Okay, thank you, Chris. Dr. Neil.
Thank you. You'll be pleased to know these are my last set of questions. And they're around disproportionate costs for lower value and medium value cases. And I know we've touched on that this is part of David Locke Casey's wider review in the role of fixed recoverable costs. But I'm particularly interested in whether there are thoughts of extending that beyond the lower value cases to medium value and above. And also, the issue of complexity of case does not always relate to the value of the claim. And there are concerns that we've heard from claimant lawyers in particular that this becomes an access for justice point. And I wondered if you perhaps could give a little bit more clarity on that point.
Yes, and those are arguments that I absolutely recognise and we've been debating for some time. I mean, just coming to the first point about the medium value end, and certainly the Ministry of Justice with its fixed recoverable cost regimes for motor and EL and PL has looked to extend the threshold over time. So starting with the very low value, then moving it up to 25,000, and is now looking at has now been moving into higher thresholds. So that's the general pattern of how these reforms unfold. The other thing I would mention is that when the policy was first being considered for clinical negligence, that is quite some time ago now. And obviously there's been an inflationary impact since then. So if you think about £25,000 10 years ago when the policy was first mooted, what that might equate to now, then you would probably be in the middle value end. Of course, on the access to justice issues for those who are severely harmed, who may nevertheless have a low value claim, is an important area of consideration for decision making in that area. Previous iterations have considered things like exceptions for certain cases, but I think what it comes down to is what the cost regime looks like and how it provides sufficient flexibility for that complexity to be accommodated.
And we talk a lot about the legal fees, but there's also the fees for expert evidence. Now, in lower value personal injury claims, there's a tariff system, or there's a cap on the cost of expert evidence. Is that something else that perhaps this is more directed to the Permanent Secretary, the department is looking at in terms of minimising costs, particularly at that lower end?
I think the David Locke's review is looking in all aspects of clinical negligence, including costs of claims and the breakdown and the way that it's worked through. So, as you'd expect me to say.
We'll wait that report with anticipation, I think. Thank you, Chair.
Thank you very much, Neil. We now come to Catherine, please.
Thank you. So we've already touched on, I think Neil highlighted it earlier, the issue of the potential double paying by the government, in effect, paying once for compensation and then again for ongoing healthcare and care services through public services. So I appreciate that that is the way that the legal system and the civil procedure is set up. What I'm less clear about is why we don't have any clear information or data, or do we, on the number of people for whom that is the case? Helen, I think it's probably a good one for you.
It's a major issue, and as you say, it relates to the legal framework. We do, in some cases, negotiate what we call a reverse indemnity or a Peters indemnity, which is the case, where we, as part of the settlement, agree either that the claimant should not access state services, or that where they do access state services, they should receive a deduction in their annual payment subsequently. So we do have a number of those arrangements in play, but we as the courts have expressly said, that cannot be imposed. It's part of the negotiation. In relation to what happens after the settlement has been agreed, though, other than those agreements, we are not able to ask for information as to either how the patient spends their money, or whether or how they access state-funded services. Unfortunately, we're not allowed access to that information. There might be mechanisms which could be put in place to get a better record of that, but at the moment that's certainly not the case.
Do you have a sense of the extent to which that, as a phenomenon, contributes to England being such an outlier in terms of the costs of clinical negligence? So I refer to figure 15 in the NAO's report, which I'm sure you've seen, and it's really stark, the extent to which the costs per capita for England are so much larger than for other jurisdictions other than Ireland. To what extent do you think that is a factor that contributes to that?
It's certainly a major contributing factor to the costs of certainly the very high value cases in terms of that privately funded basis of the assessment of future care. In relation to other jurisdictions, I think the NAO's table is very helpfully caveated to explain that it's not a like-for-like comparison. There's nothing quite like the NHS, nothing quite like what we do in terms of indemnifying the NHS. It's fully comprehensive, and often other jurisdictions only report on different elements of the system because some of it's privately insured, some of it's capped, some of it is a top-up. So they're not like-for-like comparisons, and I think the NAO has been very clear about that in its report.
Yeah, and presumably that's something that will be looked at as part of the ongoing report into this issue by David Locke.
Certainly, any policy development looks at international examples as part of any of its development. I would reinforce what Helen just said in terms of the uniqueness of the NHS and the universal health system that we have.
Yeah. Okay, that's really helpful. But on the flip side, we've talked a lot about the money and the costs. But I think there are equal concerns about the impact on outcomes, patient outcomes, and that the current system, you could argue, and I think it's worth discussing today, is counterproductive to improving patient care in some cases because of the system itself creating a lack of openness and transparency and candidness with patients and indeed within the health service itself. Because the DASH review did find that the current complaint system is very confusing and it lacks responsiveness. So it'd be really helpful to understand to what extent the NHS does centrally collect information about how trusts respond to complaints. And I appreciate I'm talking about complaints rather than litigation, because clearly if we had a system that dealt better with complaints, we would have a reduction in litigation. So it'd be useful to understand how the NHS collects that data and make sure it does filter across the whole NHS in England to make sure that we can learn from where mistakes are made.
I think the complaints are collected centrally in themes, so there is learning from complaints centrally, and there are, and it's off the top of my head, it sits within the nursing directorate, but I think 200 to 250,000 complaints nationally that are looked at and themed each year. I think the administrative nature of them comes up, and you mentioned Dr. Dash, and Dr. Dash and I were only a week ago on a call with a particular provider that had changed their complaints process, always to offer a face-to-face appointment as the first thing, and we're looking at other models of it. From the point of view of litigation, I think I'm right in saying that about half the people who litigate have gone through the complaints system first, which also, of course, means half of them haven't. So it's hard to know the distinct connection, but making sure people are treated well in the first place is clearly important, so that they're not frustrated and go down a legal route where it could have been dealt with locally. So I think we're open to new models, and I think it's also important to emphasise that Dr. Dash and all of us are very keen on doing more in patient experience. So whilst I don't accept that we've talked too much about patient safety, as is sometimes said, I think we've talked about it a lot, and rightly so. We recognise that we need to think more about clinical effectiveness and patient experience as the other elements of quality, and all of that will be part of a new quality strategy, which will include going very heavily into greater patient experience, thinking about complaints, and a new director of patient experience in the new structure.
Do you think we allocate enough resource to deal with this?
Deal with complaints?
Deal with complaints?
Well, I think it depends whether you think the current process is optimal, and if you don't, then it's a question of what a new model would look like and what that would mean in terms of resource. I mean, clearly, if you took an approach, for example, of saying it's much better to do this face-to-face than by correspondence, that is clinical time that will be taken up addressing those issues. Now, in my own practice, I found that incredibly helpful. It is very difficult to lay out some of the complexity in letters. It's much easier to do it face-to-face. And you know, I got great value out of that, and I would hope that patients and relatives did too. But it does take up considerable amounts of time, which are not to be underestimated in the current circumstances.
Just in terms of that initial response actually contributing to reducing future harms, one of the complaints I know that has been made is that the NHS is, and it's been said, is drowning in patient safety recommendations. So every time there's a complaint, every time there's an incident, every time there's a never event, there are recommendations that come out of that, but it doesn't necessarily seem to be streamlined and coordinated or necessarily rolled out across trusts in a manageable way so that they can be meaningfully implemented. Do you have a response to that as a concern?
There are a lot of recommendations out there, and we're having to manage those. We are looking at a new approach with the new National Quality Board to how we can make more sense of and get better, stronger, smarter recommendations. I mean, I think during the Thirlwall report, they identified in excess of 1,500 recommendations in the system. But of course, managing those centrally is a huge task, and we would have to be careful what we sort of set ourselves up to do in order to look at that, and they are sent to a variety of places. But we are, I think, getting better at setting up the way we sort of set investigations and so on, to say when you finish this, we want a very smart set of recommendations, and making 300 recommendations is not going to be helpful. We need to manage that practically.
Because that's one of the things that's really hard when you hear some of the really, really tragic cases that happen, particularly in maternity services, is often where they reach the public attention, and you hear it happening in one trust and then you hear it happening again in another, and the lessons may be learnt within that trust, but they're not necessarily effectively rolled out across the NHS. So, you know, what are we doing to improve that as a systemic challenge?
When we pick up safety issues that are likely to occur elsewhere, then we have a variety of mechanisms appropriate to the particular circumstance of which we can notify people, including national patient safety alerts, for example, which we, I think, are issuing one just about now on penicillin allergy. And they are appropriate for certain sets of circumstances. Sometimes a more targeted approach is appropriate. And it's one of the things we've revised is how we issue those alerts to make them more effective.
And can I just ask, do you collect the data on the never events and to what extent they become clinical negligence cases?
I can't tell you how often never events become clinical negligence cases.
I think the challenge is that it's a skewed perspective, as Professor Fowler was referring to earlier, that we kind of get to see the tip of the iceberg, and it's often driven by other factors than the level of safety. We did capture never events with a flag on our system a while ago, but then the definition has changed over time as well, and so there's some discontinuity in the trends to address. I can have a look at that and perhaps come back to the committee on that point as well, if it's helpful.
Would be helpful, because
to be fair, we're not making Helen's life easier by changing never events. And importantly, and there's been a consultation which is ongoing on never events, because some of them don't meet our own definition of never events. So there's a slightly perverse situation where not all the never events are never events. In the ones that are, i.e. there are preventable, there are barriers that prevent them, actually, I mean, if I give, for example, gas misconnection, we have gone from a state where there are about 10 of those a month to where we now see 1 or 2 a year. So we have intervened to act, and it's important that we do that. There are a very, very small proportion, about 500 a year, of the incidents we see, and so they to some extent you could criticise them for being skewed and getting more attention than other areas that are perhaps more egregious, which I accept. They can sometimes be a useful window into the sort of governance arrangements of particular organisations.
Because the challenge seems to be to have a culture within the NHS that encourages practitioners, medical personnel to be open about when a mistake is made and learn those lessons. But I think the litigation culture and risks weigh against that and that openness and transparency. And I think getting a system that can enable both, I think, seems to be where we need to get to. Would that be a fair assessment?
Well, I mean, if you look at never events specifically, when they first came in, they were associated with fines, so that didn't do a lot for transparency. So I think it's important that we encourage people to be open by making sure that they are not inappropriately punished when they step forward for that.
And just admit I've made a mistake.
Yeah, and I think, I mentioned earlier that the way we investigate has changed to a system called the Patient Safety Incident Response Framework, slightly heavy-handed, which replaced the Serious Incident Framework. And when you see what people are doing with that, and I went to the meeting discussing some of these issues in a large London teaching trust, it is very clear that they are being very open, they are addressing the issues for the patient first, and then looking at what they've done in a very neutral, non-blaming way and learning from it very effectively. And they're also looking at what their most significant issues are and focusing on those and not losing them in amongst a whole variety of other things.
Can I just add from a perspective of the compensation system? One of the things that's incredibly important to us is that we continually reiterate the message that openness and transparency is absolutely the best way to prevent a claim in the first place. We've done that consistently, and we have supported that with both guidance and materials and an animation more recently, and then trust by trust training on why that is so important and how it can be delivered well. I think often the concern around transparency is much more complex than the compensation system. It goes into things like disciplinary processes and the employer's own actions, all sorts of other areas which are not necessarily about the compensation system, and we are absolutely clear that that is fundamental to preventing a very difficult claim further down the line.
So I think, the rest of my questions were looking more at what solutions are you considering to this, but I understand that will be part of the ongoing inquiry and report that we're reporting back, so I'm happy to leave it for now.
Thank you, Catherine. I want to follow up 3 questions, please, from what Catherine was asking. One, first with you, Professor Aidan. It does seem that some trusts have more serious obstetrics and gynecological, some of the high-value claims than others. So taking Helen's point, how do you implement a lessons learned there? How do you implement for the individuals involved retraining where it can be identified to a particular individual? Because, as everybody says, preventing these serious cases is far better than having to litigate afterwards.
So, the units are very carefully monitored. We have leads, the Chief Midwifery Officer and a National Clinical Director for Obstetrics and Neonatal Clinical Directors that are constantly monitoring data around these organisations. And there is a maternity support programme that currently has, I think, about 30 trusts within it, where there are concerns, where there are active support mechanisms with senior leaders and support advisors who are embedded in the trust, supporting those trusts to try and drive down those incidents.
Thank you. 2 questions for you, please, if I may, Helen. Catherine touched on the whole issue of double counting in awards, and particularly around Section 2.4 of the Law Reform Personal Injuries Act 1948. You may not, under cover of the Home Secretary's dictum, want to comment on this whilst the learned QC is looking into this, but can we be absolutely assured that this is a matter that he will look into? You may want to say more than that.
As I previously said to the committee, all aspects of clinical negligence, including the reasons behind it being considered as part of his review.
Wonderful to get out of jail card free, isn't it?
Can I ask one more question?
Yeah, of course.
Just to follow up on the complaints, do you collect the data on how quickly complaints are responded to? Because I think there's a really important correlation between, as I think you've identified, Helen, that responsiveness to complaints and them not needing to then convert into litigation. But do you actually collect that data from all trusts?
There are standards for complaint response time, and data around those are collected, yes.
Okay.
I couldn't...
That's publicly available? Because I think it is for some trusts, but not for others, from what I've...
My belief was it was publicly available. It doesn't sit within my purview, but we could feed back to you on that, I'm sure.
Second question for you, Helen, and it's a more generalised question, so I'm hoping I'm going to get round the Permanent Secretary's dictum. One of our witnesses at the pre-hearing said, and I quote, I won't say who it was, but I quote, "I find it really quite concerning that the number of mediations and alternative district I think it does say district, but that may be a misprint, resolution is actually dropping, not increasing." That does seem to be going in the wrong direction. Why is that, and what can be done about it?
So first of all, it's not true. The number of cases that are being resolved outside of litigation has increased very substantially, and we've driven that as a key priority of ours. It's 83% now. What that person may be referring to is mediation, which has fallen, but only because we've replaced it with other ways of resolving cases. You don't need a full-blown mediation if all the family wants is a meeting with the relevant clinician, or they want to get in a room with their lawyer present to have a discussion about the case for 2 hours. So mediation, we are obviously still promoting and still use for the appropriate case, but we use a whole range of other alternative dispute resolution methods to resolve cases without going near court.
I think I did in the quote say mediations and alternative dispute resolution. I got a misprint there. Okay, fine. Sarah Green, please.
It's just a brief one, really, just to follow up on that, the initial response to harm. And it's a question to you, if I may, Helen, because I know that NHS Resolution has done some research into this. I'm keen to understand from your perspective how you think the NHS is responding to that research. Just to give you an example from my own seat, it's not just about individuals who are looking for answers or reassurance ending up in litigation because they're not getting the answers. I've got examples in my own seat where simply asking questions automatically results in it being treated as a complaint. So I'm keen to understand what response NHS Resolution has had to the reports that you've done.
Yeah, and it's a really important issue for us because we know that upstream part of the process is key. And actually there's a helpful infograph in the NEO report, which is actually ours, which shows that that's quite an extended period in its own right. It's often, it's on average around 3 years until we hear about a claim, before which a lot has happened as between the patient and the treating organisation. Trusts have been really receptive to the work we've been doing with them. Our events are often oversubscribed. We get numerous requests for our safety and learning team to engage with local organisations because it is a supportive approach. We're not a regulator, and so it's something that seemed to be supportive and welcome. I think ultimately a complaint is feedback like any other type of feedback. And what we try to encourage is that you shouldn't end up in any formal process if you can avoid it. If you can give answers as close as possible to the treatment when the patient is ready to talk about it, that's by far and away the optimal solution, rather than requiring somebody to put it into a formal complaint or put it into a formal legal process.
Just to follow up on that, and you may feel like you can't answer this, so it might be a cheeky question, but is your sense that it's quite a defensive culture within the NHS, that they automatically go into defence mode when any questions are asked? Or I apologise if that's a question you don't feel you can answer.
No, it's a good question, and I think, the answer is it's variable, and there's a lot that we can do to improve things for patients, undoubtedly. So, perhaps, Professor Fowler, that might be something you want to comment on.
Firstly, not all complaints are about medical care. Some of them are hotel and services type complaints, so there are a mix of things. I think, at the risk of repeating what I said earlier, we are very open to other models of doing this and making sure that we reduce the level of confusion, because there are many ways in which patients can approach us when they have concerns. There are many different mechanisms for doing it, and I think we need to simplify that so they know how to bring forward concerns. And I think the point about it turning into a complaint, because that's the mechanism we have, is an appropriate one to say, is that ideal? And we know that there are people who've worked on this who've got very good models. So, for example, and I'm not saying this because it's Jim Mackey's trust, but we know that Newcastle, just to be clear, have a very good person who leads on some of this stuff, and we've looked at that, and they are part of our group looking at the quality strategy of what can we learn from that and how can we make that more embedded. And as I said, this discussion with Lincolnshire, there is a model there that we will now look at and say, how do we do this better as part of that? Patient experience is one of the sort of 3 pillars of quality that we're looking at, and we're looking for better mechanisms for doing it, because I don't think it works well for staff or patients in all circumstances. I think it works, to be clear, very well in some places, but it is a bit patchy, and we need to try and make sure it's consistently good for both staff and patients.
Thank you, Chair.
Thank you very much, Sarah. Catherine, please.
Oh, thank you. That's very kind. I just wanted to come back on a comment that was made about training, and how you learn from complaints and you learn from mistakes. To what extent are you monitoring the training compliance? Because my understanding is it's not 100%. and in some cases it's far from it. And you would think that one of the first steps you could take to prevent clinical negligence and mistakes being made is to ensure that mandatory training is undertaken.
Okay, so I think two important things to say. Firstly, training is not always the solution to safety issues, and indeed is not a very effective barrier. I mean, if you look at safety science thinking, it's one of the least effective barriers thing, just telling somebody not to do it again. So we're always looking for how we can build in resilience and how we can make systems such that human error, which is what we're talking about, is less of a concern and gets picked up. So it's not always the answer. Where it is, I think there is a really important piece about statutory and mandatory training, and we are doing a lot of work on that at the moment, because it's become quite burdensome and a bit haphazard, and not all training is good quality, and we haven't always looked at the impact of that training on outcomes. So there's a lot of work going on in NHS England at the moment, which will become part of the whole, around, so what does effective training look like? What is the impact of that on outcomes? What is essential and what isn't essential? What are the sorts of areas of training that people might want to pick up and do because it's interesting, and what should we be requiring people to do? And, you know, we've had to have discussion with the likes of the fire service around fire training, say, how do we do this better? And the work, actually, one, it will increase the quality of training, but also we're already estimating we can give back 100,000 days of activity as a result of reducing the burden of training, making sure each time you move you don't have to do the training again if you've done it recently. So it's a really important area, and there's a whole piece of work around it which I think will make...
Can I come in on that?
Yeah.
Also, and I'm glad we've had a bit of this morning, but there is an awful lot of blame culture in the NHS. And training is much more than about don't do that again. It's here's a technique, but you could do it better. Oh. And so maybe a sort of a different approach to all of this. Instead of blaming something when somebody goes wrong, say, well, look, how can we help you to get it right the next time?
Yeah, absolutely.
Can we embed that more in the health sector?
I think that is happening. So there is that in training, making sure people do understand what options, and for example, making sure that things like NICE guidance are followed more and are part of training of here is what's going on in NICE recommendations that you should be following in your practice.
I interrupted, Catherine.
No, that's really helpful. That's reassuring that it's being looked at. I guess what we need to see is the data that would help to understand to what extent training would have made a difference in terms of clinical negligence or even just complaints.
Yeah.
And I think what I'm really getting from this session today is that we need a lot more data on quite a number of areas so that the NHS can respond in the most productive and constructive and efficient way possible in terms of taxpayers' money. That was a bit of a statement rather than a question.
No,
I recognise that.
Right, Anna, please.
Yes, thank you. And thank you to our witnesses. It's really great to hear the commitment to continuing patient safety work and making sure that there is action and learning. We've had now the duty of candour for some time within the health service, obviously Hillsborough Law bringing that duty of candour more broadly. I'd just be really interested to know to what extent you genuinely believe that duty of candour to be fully embedded within the NHS.
And I rather wish you'd asked me this in a week's time, because I've got a committee on that next week, so I'll be better briefed. But I think in all seriousness, duty of candour we recognise has been a bit mixed. There is an ongoing review by the Department of Health around duty of candour. Obviously, we're looking at and taking into account what the Hillsborough Law means for the health service. It supports what we're already doing to some extent. And I think it is really well done in some places and is a really important thing. And I think in some cases it just encourages people to do what they naturally wanted to do anyway and perhaps felt inhibited by the threat of litigation or whatever from. So it is saying to people it is absolutely right to be candid about it. And I think that the review will look at some of the complexity of it, is recognising when it's appropriate and when it isn't. So, you know, there is a set level, moderate harm. Well, what constitutes moderate harm, and is duty of candour enacted, and so on. And when is it appropriate? Sometimes we have to do it retrospectively. So we pick up an issue that's historical, and we then have to apply duty of candour, and there are pros and cons to that. So I think a lot of that is the subject of the Department of Health review, which I haven't seen the outcome of yet, but that will be saying, okay, we've had this for some time, it's a stop, look, see how it's going, and what more could we do, or what could we do differently to enhance the use of it.
I mean, I hope you understand why I'm asking, given how important we're saying an open sort of culture is to reducing harm. So I just wanted to ensure really that you saw the duty of candour as something that was going to support and enhance the safety culture.
Absolutely. Yeah.
And secondly, the DASH review obviously looked at the fact that there were many organisations with different responsibilities in this space. And so I suppose I come back round to where we started. You know, there's HSIP, I've heard, and I've learnt of a new one today, the MSNI. Obviously, you've got the NHS resolution, the patient safety work that's going on within NHS England, which obviously will get reorganised into the Department of Health, the Patient Safety Commissioner. There's a lot of reorganisation of those bodies, some consolidation to reduce duplication. How will you ensure that when you come out the other side of this, and also while you're going through it, that there is real clarity about the responsibilities and accountability for patient safety in this system?
I think this is an important point, and we think of patient safety in a number of phases, one of which is the middle phase, which is referred to as the bureaucratic phase, where things can become quite burdensome. And these bodies are brought in for good reason to address an issue, and in changing them, you just have to be sensitive to the fact that you don't want to go back to where you were before they were brought in. There is a lot of change going on. MNSI is the Maternity and Neonatal Investigation Unit that was part of HSIB as it was at the time, and then was taken into CQC. The current plan, as I understand it, is that HSIB as a whole will go into CQC, but we need to be careful that it maintains its independence in doing so. We already work with all these bodies. We already work closely on the safety agenda. We get together and discuss issues and make sure that we are sighted on what's going on as a group. I think from an efficiency perspective and a public perspective, you would want to look at rationalising that where possible, but just taking a cautious approach that means you don't accidentally set yourself backwards by removing a bit of bureaucracy that's there for a very good reason and is having an important function.
From the public and probably a clinician point of view, when are they going to see this change, both in terms of reduced harm and a simpler system to navigate?
I think that the simpler system is coming already. So the Patient Safety Commissioner is now part of MHRA. There are movements across for some bodies to be in CQC. There are movements to take functions out where they're felt to be repetitive. From the public perspective, I would go back to where I started, which we are already seeing reduction of harm as a result of patient safety efforts. So we are doing our best to calculate that. As I say, it has caveats, but we're estimating, on a avoidance of death basis, 1,000 a year at the moment. We want to go further than that. That's kind of 9-10% of the whole, and more so in other harms. So we are actively working on it. We're seeing the impact of that. Some of the big policy areas, such as the Patient Safety Incident Response Framework, which I think will have big impact. We've seen impact already in sort of smaller providers, where they're coming forward saying we have halved the number of incidents as a result of the work of this. Now, I'm not suggesting for a minute that everyone will be able to do that and quickly, but it will have impact over time. It's relatively new.
May I finally ask Helen, in terms of this committee coming back and having a look at those public liabilities from clinical negligence, which sit, I think, second to only nuclear decommissioning, recognising that much of that is baked in because they are claims that go well into the future, how quickly and how rapidly do you think we will see a fall in the new claim totals and new liabilities?
I think that's unfortunately an impossible question to answer because, as you say, firstly, a lot of it's baked in, but also claims trends can very much be influenced by things like the legal environment. The last bump we saw in claims volumes was because of a major reform to funding arrangements through the LASPO reforms back in 2013, which had absolutely nothing to do with safety. So much though I would like to be able to say when the curve will turn, I'm not in a position to do that, unfortunately.
Maybe then, Samantha, you could have a go at it. I mean, the whole purpose of the whole hearing today is how can we bear down, whether that be on claims themselves, harm, claims, legal costs. You know, you've given us answers of a lot of things you say are being done. Is it going to make a difference?
So the purpose of the David Locke review is to scrutinise and to make sure that we are able to address all the things that have been outlined today. And as I've previously said on a number of occasions, the review is with ministers. That is the purpose of the review, though, is to absolutely address the rising costs of clinical negligence. If I may, just to go back to your previous question about accountability, which I think is really important. So Dr. Dash's review of patient safety identified it was cluttered, and there were a number of different bodies that had responsibility for patient safety quality, which as part of the 10-year plan sets out how we will be approaching overseeing quality and safety in the future. The more specific point on accountability I wanted to make is that it is frankly something that Sir Jim and I are very focused on as we go through this transformation, is who is accountable for what, specifically between the Department of Health and Social Care, who's responsible for it within NHS England. And as we go through this joining, through this transition period, maintaining independent responsibilities, being very clear. So who has responsibility for what arm's length body, what particular aspect, where does it get reported, who and how, what is the timeline associated with it? Because there is a risk through this change, but there is a specific focus on accountability.
Thanks. And with apologies, Chair, I think at the start of this part of the hearing, I should have declared that I'm an officer of the All-Party Parliamentary Group on Patient Safety.
Thank you for putting that on the record. Are you completely finished with all your questions?
I am, thank you.
I want to ask one or two more questions. And firstly, with you, Professor Aiden, I think the NHS could do more to help itself. The duty of candour we've talked about, but I've been involved in some of these cases, and my constituents have just said, all I want is an apology. Very difficult to get in some cases, and I think it's because people in the NHS are afraid of being called out for having got something wrong. Now, we all make mistakes in life. But I just do think the NHS could be more open and admitting where things go wrong quite quickly, because that might keep some of these lower value claims out of the courts.
And I think we are endeavouring to encourage a culture in which that is exactly what happens. There's no resistance to that centrally, certainly, except that it's not, your constituents' experience, and I'm one of your constituents, is that it's not always perfect.
The second thing is how complaints are dealt with. Maybe this is a question for you, Helen. I've had cases of where people, things have gone wrong and they've had very great difficulty getting their medical records. Now, I assume that's because the NHS is worried about litigation, but that surely ought to be no excuse for delaying people getting access to their medical records, actually the hospital records, what actually happened in intensive care in that particular time. Whatever the NHS has should be fully open and available to any patient that wants it at any time, surely.
Yeah, I completely agree, and there's laws around that as well, and rules that trusts are required to comply with on disclosure of records, and that shouldn't be happening. One of the things we're doing is we've regionalised our teams so that they are working across all areas locally with NHS trusts, so that they can identify where there are particular issues that might escalate into something further down the line. And disclosure of records is clearly one of those, because if a patient isn't able to get a reasonable response to a reasonable request, they may well then go to a lawyer to help them out with that.
And that's often what happens. Wondering at the bottom end whether that would help to keep some of these low-value cases out of the courts. On that subject, I suppose it's and I know we've had a lot out of this get out of jail free card today, but I'm just wondering whether your organisation is open to change enough, and whether we will need to change the system for these low value claims. And I can't stress how unsatisfactory this system is, where claims of 25,000, the legal fees can be up to 100,000, 4 times. This is just a nonsense. And I'm just wondering whether we will need to mandate some form of alternative dispute resolution for these low-value cases. Maybe mediation we talked about, maybe alternative dispute resolution, maybe the Ombudsman. But is David Locke looking at all these areas?
David Locke is looking at all aspects of clinical negligence and the cause behind the rising costs. And I am not trying to subvert the committee at all, and I know that we'll be coming back at various times to talk about it in the future, but his review is currently with ministers, but I can assure the committee that he's covering all aspects of clinical negligence, and the government is committed to addressing it.
Thank you, Permanent Secretary. I mean, quoting the same gentleman that I quoted before, the issue for me is that over the last 25 years or so, there have been repeated inquiries and reports. The NA report of 2017 gave exactly the same conclusions as it did for 2025. I really hope, for all of our sakes, for the patient's sake particularly, that this review is going to really produce something different to what we've got now, and it's going to be acted on in good time. Otherwise, I fear we're going to be having you back before this committee a lot of times in the future. I also have to say that we weren't terribly satisfied with that your department had really thought through the changes to local systems, exactly how these redundancies were going to be operated, what they were going to cost, how the money was going to be dealt with. So I think it will be probably, after we've considered this whole matter, I will be writing you a fairly comprehensive letter asking for some questions. But I do have to say, if we don't get answers to those questions, it may well be that we want you back here in the fairly near future to explain what is happening. So thank you for your help this morning, everybody. It's appreciated. Order, order.